In this module, I am going to discuss about an important group of liver disorders called metabolic liver disorders. I am going to discuss the condition which I have listed in this, which includes alpha-1 antitrypsin deficiency, Wilson disease, glycogen storage disease, tyrosinemia, galactosemia, and hereditary fructose intolerance. First topic I am going to discuss is alpha-1 antitrypsin deficiency. As I have said in the previous module, alpha-1 antitrypsin deficiency, it is one of the commonly inherited group of metabolic liver disorders. But fortunately, it is relatively less common in India when compared to Western population. Okay, right. It is an inherited disorder and the mode of inheritance is autosomal recessive mode of inheritance. In fact, most of the metabolic liver diseases, you will study only autosomal recessive mode of inheritance. The genetic defect in this condition is SERPINA1 gene, which is located on chromosome 14. It is in the long arm of the chromosome 14, so I'll write it as 14q. This is the usual genetic defect in this condition. The problem here is going to be deficiency of alpha-1 antitrypsin. It is actually not decreased production of alpha-1 antitrypsin, but production of an abnormal form of alpha-1 antitrypsin, which is a misfolded form of alpha-1 antitrypsin. Okay. So before saying about the features of this condition, let us see what is the normal role of alpha-1 antitrypsin. Alpha-1 antitrypsin is produced in the liver and is carried by the blood and enters into the lungs. In the lungs, it will protect the lung tissue, especially the acinus. We all know that acinus is composed of the respiratory bronchiole, alveolar duct and the alveoli. So that acinus is protected from destruction by neutrophil elastase. So this is the normal load of alpha-1 antitrypsin. Let us see what happens in this alpha-1 antitrypsin deficiency. As I said before, there is production of abnormal or misfolded forms of alpha-1 antitrypsin. So what happens? They are not entering into the lungs. They are not entering the lungs at all. So what is the problem? Lung tissue is not protected from the neutrophil elastase. So the neutrophil elastase starts destroying the lung tissue, resulting in emphysema. There's a very famous question. What type of emphysema they develop? It is all parts of the acini is getting destroyed. So it's called pan-acinar emphysema. Okay. Second, the abnormal alpha-1 antitrypsin, after being produced in the liver, is stored in the liver itself, or it accumulates in the liver. But once it accumulates in the liver, it causes toxic damage to the liver cells. That is why these patients can develop liver damage due to alpha-1 antitrypsin deficiency. These are the two main effects of alpha-1 antitrypsin. Okay, right. Now, some genetic part of it you also need to know about. When we talk about the expression of the alpha-1 antitrypsin or phenotypic expression of the alpha-1 antitrypsin, it is remembered as two alleles. Okay, for all of us, the normal allele of alpha-1 antitrypsin is PIMM. Okay, Pi here stands for the protease inhibitor, which is the other way of describing alpha-1 antitrypsin. Because alpha-1 antitrypsin, I said, it inhibits neutrophil elastase, so it is considered as a protease inhibitor. Very simple. Here Pi is a protease inhibitor. M and M refers to the two alleles of alpha-1 antitrypsin. A normal allele is M, so that is why I have written as M and M. Z allele is something which is abnormal. Okay. And in patients with alpha-1 antitrypsin deficiency, what type of allelic expression you get? It is PIZZ. This is the point I would want you to remember. Okay, so this PIZZ phenotype is a problematic condition and results in the features which I have described before. Okay, so the common features are going to be liver damage due to accumulation of abnormal alpha-1 antitrypsin in the liver. But please remember, 80 to 85% of affected persons, the liver recovers completely. Okay, or in other words, as these children become older, the liver damage subsides by itself. This is a very, very important fact which you should remember. Or in other words, only 15 to 20% cases, they develop CLD or chronic lung disease. This is a first point to be noted. The second point to be noted is they can develop emphysema, and that too pan-acinar emphysema. However, pan-acinar emphysema does not develop in the childhood. It does not develop in the childhood. It usually occurs when they become adults by around 30 to 40 years of age. Okay, and here is a very important point. Smoking increases the risk of development of pan-acinar emphysema. So in all cases of alpha-1 antitrypsin deficiency, limiting the exposure to tobacco smoke is very, very important. These are the usual features of this particular condition. The investigations which we can do in these patients include measurement of alpha-1 antitrypsin levels itself. This is obviously going to be low. What is low levels? It is typically values less than 50 to 80 milligrams per deciliter. This is what is low value of alpha-1 antitrypsin. You can also do the genetic testing to look for defects in the SERPINA1 gene. That is one of the best ways to confirm the diagnosis. Another important way by which we can confirm the diagnosis is by taking the liver biopsy. What are you going to look for in the liver biopsy? We are going to look for the abnormal misfolded alpha-1 antitrypsin in the liver, and that is shown by the picture here. This is the liver biopsy specimen. Here we have used a special stain, not the routine stain. We have used a special stain where you can notice very clearly that intracellularly, see, suppose this is one hepatic hepatocyte. You can see inside that there is a lot of dots seen. This is one more hepatocyte where again lot of globular inclusions are seen. All these globular inclusions are the abnormal forms of alpha-1 antitrypsin. As I said, we have to use special stain. What is that special stain which we are using here? It is PAS positive, that is periodic acid shift stain positive. And one more is, it is diastase resistant. That is a typical description of abnormal alpha-1 antitrypsin. And don't forget, they are accumulating intracellularly. So they are present as intracellular globules. These are the typical words in the liver biopsy report you will see in a patient with alpha-1 antitrypsin deficiency. Now coming to the treatment, please remember most of the times the treatment is symptomatic. And remember, as I said, a good number of patients, they completely recover from the liver damage, and only very less number can develop emphysema in adulthood, and that too if you can avoid and limit the exposure to cigarette smoke, that chance of developing emphysema is also greatly reduced. So treatment is all supportive treatment. Okay. In adult patients, infusion therapy is advised, where you infuse normal alpha-1 antitrypsin which can be collected from healthy donors. But this infusion therapy has got a role only in adults. It is not used in pediatric population. Okay, right. And ultimately, if some of these children go on to develop chronic liver disease, liver transplantation also will be helpful. Okay. This is about the salient points of the first metabolic liver disease, that is alpha-1 antitrypsin deficiency. The next disorder is Wilson disease, which is a well-known condition. You must have studied in so many other subjects as well, because Wilson disease is a multi-system disorder. Talking about some basic aspects of Wilson disease, it is caused by a defect in the gene ATP7B, which is located on chromosome number 13. Okay. This ATP7B gene codes for a specific protein called P-type adenosine triphosphatase. Okay, what is a normal role of this protein? Remember like this: copper enters into the body from gastrointestinal tract, from where it is entering into the liver via the circulation. In the liver, the copper has got two methods of disposal. One, it combines with the ceruloplasmin and it is circulating inside the body to do the metabolic functions. Second, excess of the copper is excreted from the liver into the bile. So normal role of this protein is excretion of excess copper into the bile, and the next role is incorporation of copper with a copper binding protein called ceruloplasmin. Please remember, the copper which is incorporated with the ceruloplasmin is called as a bound copper. Why this is very important to know? Because bound copper, when it is in the blood, it is non-toxic. Okay, so this is a basic function of the protein produced with the help of ATP7B gene. In Wilson disease, what is the problem? This ATP7B gene is defective, so this protein is not going to be produced. This results in impaired excretion of copper. Okay, it is not excreted in the bile. This will result in accumulation of copper in the liver, which would cause liver damage. Okay, that is the first effect. Second effect is the copper is not getting incorporated into ceruloplasmin. So there will be increase in the levels of unbound copper, or what is also called as free copper. Now please remember, this free copper is toxic to the body and it will cause different manifestation which we are going to study as features of Wilson disease. So I am going to tell you about the clinical features of Wilson disease next. As I have said, one of the characteristic features is liver damage, where the child can develop chronic liver disease, CLD, which can even lead on to cirrhosis in the late stage. And remember that the age at presentation, that is with jaundice and all, or features of liver disease, is usually after 1 to 2 years. The typical age at presentation is around 3 years. Okay. Second important set of features are related to eye damage caused by this copper. Characteristic eye damage is in the form of a ring called as a Kaiser-Fleischer ring, which is seen in the cornea due to deposition of the copper in the descending membrane of the cornea. A very characteristic association. Most of us know it already. The next important feature is development of cataract, the characteristic sunflower cataract. These are the two features due to copper toxicity in the eye. The next important feature is neurological manifestations. And it's a very famous question often asked in the exam. Which part of the brain is more affected by copper damage in Wilson disease? It is basal ganglia damage. Okay, so these patients can develop abnormal movements, tremors, as well as due to brain damage, they can have increased risk of seizures. And many patients, especially adults, they can have psychiatric manifestations also. Okay, and there can be a question in the exam. If there is a brain damage in Wilson disease, what is the first change or the first feature of brain damage noted in childhood? Your answer has to be deterioration in the school performance. Very, very important point. So the child who was performing well at the school, I'll do that again. So a child who is performing well at the schools in terms of academic activities and all, now starts to show a decline. That is the first change of Wilson disease induced brain damage in children. Okay, now before I discuss further, I want you to remember this very, very clearly. Wilson disease can have an onset either in the childhood or in the adults. Childhood onset Wilson disease, classically presents with chronic liver disease or liver involvement, whereas adult onset form of Wilson disease usually presents with neurological manifestation. So these two are important MCQ questions which I want you to remember. Other manifestations of Wilson disease includes copper mediated hemolysis of the RBCs. Very important, this is hemolysis mediated by copper directly. So if you do Coombs test, what is going to happen? Will it be positive or negative? Obviously, Coombs test will be negative in this situation because it is not mediated by antibodies. Coombs test will only be positive in antibody mediated hemolysis, but here the hemolysis is due to copper toxicity. That is one thing. Patients can also develop arthralgia, joint involvement. So these are the usual features of Wilson disease that one needs to remember. Next is about the investigations which we can do in Wilson disease. Investigations can be remembered as screening investigations and confirmatory investigations. Screening investigation would be to look for increased levels of urine copper and decreased levels of serum ceruloplasmin. However, if there is a question like what is the confirmatory test for Wilson disease diagnosis, your answer is going to be liver biopsy. Some of the changes which you can see in the liver biopsy include, number 1 is macrovesicular steatosis, and number 2 is the presence of Mallory's hyaline, or what you call it as Mallory bodies. Please remember, Mallory's hyaline or Mallorin bodies is not a specific feature of this condition because you must have studied that Mallory's body appearance in other conditions also like alcoholic liver disease. However, if the liver biopsy specimen taken from a child is revealing that there is presence of Mallory's hyaline, it is very, very, very suggestive of Wilson disease. Or in other words, I can also put this MCQ like this. The most common condition associated with the presence of Mallory's body in the liver biopsy is Wilson's disease. Very, very important one-liner that you should know. You can also do the assessment of copper levels in the liver tissue. Obviously, there would be increase in the levels of copper in the liver tissue. How much increases diagnostic of Wilson disease? It is more than 250 microgram per gram dry weight of the liver tissue. This is what is diagnostic of Wilson disease by liver biopsy assessment. So that is about the diagnosis of Wilson disease. We now move on to treatment part. Please remember, our aim in patient with Wilson disease is to decrease the levels of copper in the body. This is achieved by limiting the exposure of copper in the diet as well as using some medications. The commonly used medications include the chelating agents for copper. The best studied chelating agent for copper in Wilson disease in pediatric population is D-penicillamine. So this is an MCQ question. What is a commonly used chelating agent for Wilson disease? It is D-penicillamine. You can also go for other types of copper chelating agent like trientine, but the drug of choice will always be D-penicillamine. Okay. You can also go for zinc treatment. How does zinc help in the management of Wilson disease? Zinc will induce a production of a substance called metallothionein, and this metallothionein will inhibit copper absorption from the intestine. That is how zinc is useful in the management of Wilson disease. Third important management is, if these patients go on to develop chronic liver disease or cirrhosis, the only management which can prolong the survival of these children would be liver transplantation. These are the usual modalities of treatment in case of Wilson disease. I am going to tell an MCQ point here. This being a chronic disease, we may have to use D-penicillamine for a long period of time. Always remember, when D-penicillamine is used for a long period of time, patients can develop one form of specific vitamin B deficiency. What is that? They can develop vitamin B6 deficiency. So it is very important that you give vitamin B6 also whenever you prescribe D-penicillamine for these patients. Because if you don't give vitamin B6 and if the patient goes on to develop vitamin B6 deficiency, they can even develop optic neuritis. So giving vitamin B6 for these patients is like a form of preventing the development of optic neuritis that occurs as a complication while the patient is on D-penicillamine therapy. So that is about the discussion of Wilson disease in children. The next topic I am going to discuss about is glycogen storage disorders. Please remember, glycogen storage disorders can be divided into two categories based on which part of the body is affected. Most of the glycogen storage diseases involve the liver, so they are called liver GSDs. The other one is involving the muscles, especially the skeletal muscle. We call it as muscle GSD. Liver disorders in GSD are more common compared to muscle disorders in GSD. Okay, so that is the first point to be noted. I am going to tell the name of different GSDs. Glycogen storage disease type 1 is also called as the von Guericke disease. Which is due to glucose 6 phosphatase deficiency. Okay. Glycogen storage disease type 2 is a muscle glycogen storage disease and is called as a Pompe's disease. Pompe's disease is due to deficiency of the enzyme acid maltase. Okay, then glycogen storage disease type 3 is again liver glycogen storage disease and it goes by the name of Cory's disease or Forbes disease. Okay, and the enzyme which is deficient here is the debranching enzyme. Glycogen storage disease type 4 is again a liver type of glycogen storage disease which goes by the name of Anderson's disease. And here the deficiency of the enzyme is branching enzyme. That's a very famous mnemonic here, A, B, C, D. What is that? A for Anderson disease, where there is a branching enzyme deficiency for B. Then C stands for Cory's disease, where the deficiency is debranching enzyme. So C for D. D is a debranching enzyme. That's how we can easily remember these two enzyme deficiencies. Next is glycogen storage disease 5. That is an example of muscle glycogen storage disease. Here the name is McArdle's disease. Here the deficiency is muscle phosphorylase. The name of the enzyme is muscle phosphorylase. Next is glycogen storage disease 6, GSD6, which is called as the Hurst disease. Pause. Which is due to liver phosphorylase deficiency. The last one is glycogen storage disease 7, which is coming under the category of muscle glycogen storage disorders and is called as a Torrey's disease. In this particular condition, there is deficiency of phosphofructokinase. So this is a basic introduction to the name of glycogen storage disorders and the corresponding enzyme deficiencies. Now, as I have said before, two forms of glycogen storage disease. One is a liver form, other is a muscle form. Liver forms are generally more common, and the overall most common type is glycogen storage disorder type 1 or von Guericke disease. This is the overall most common type. There can be another type of question, which is the most common type of muscle glycogen storage disorder. Then your answer is McArdle disease. McArdle disease is the most common muscle glycogen storage disorder. These are some important one-liners that one needs to remember. Next, I want you to remember some common features as to how to differentiate whether a glycogen storage disease is a liver type or a muscle type. First point to know is what is the role of glycogen in the liver. During fasting, when the sugar level goes down, the glycogen will break down to produce the sugar. That is the basic role of glycogen in the liver. So if it is a glycogen storage disorder, the opposite happens. What is that? During fasting, the glycogen will not break down into glucose, thereby resulting in hypoglycemia. So the characteristic feature by which we identify liver glycogen storage disorder is fasting hypoglycemia. The key word here is fasting. Fasting hypoglycemia. And because of this hypoglycemia, some children can even present with seizures also. Hypoglycemic seizures also. And second thing, because the glycogen is accumulating inside the liver or stored inside the liver, there would be hepatomegaly also. That is a common feature of all the liver glycogen storage disorders. Whereas muscle glycogen storage disorders, how do they manifest? Again, normal role. During a resting state, muscle does not depend on glycogen for energy production. It's a well-known fact. Only during exertion, the muscle is dependent on glycogen for energy production. So, if there is a muscle glycogen storage disorder, what is going to happen? During exertion, that energy from glycogen will not be produced. So, these patients, they will present with exertional fatigue. That means weakness at the time of exertion. That is a typical feature of muscle glycogen storage disorders. And another unique feature is that when these children take rest after an exertion, the muscle weakness will improve. This is also a characteristic feature. So the patients will tell you like this: once I am exerting or running, I have a lot of weakness, so I take rest for some time. After taking rest, again it become energetic and I can do the activity again. So this is nothing but recovery of fatigue with rest. And this is called as the second wind phenomenon. Okay, so these are the common features of muscle glycogen storage disorder. Now, I am going to tell you about salient points of each of these glycogen storage disorders. First one I am going to discuss in detail is about the most common type. What is that most common type? It is von Guericke disease. Okay, let us see what happens in this condition. As I told you before, there is deficiency of enzyme glucose 6-phosphatase. This glucose 6-phosphatase is actually an enzyme which catalyzes the last step of glycogen conversion to glucose. What is that? Glycogen by so many steps gets broken down into something called glucose 6-phosphate, which I am writing as GLU6PO4. And with the help of phosphatase enzyme, the phosphate will be liberated out or released out, resulting in the generation of glucose. What is going to happen in case of von Guericke disease? There is severe deficiency of glucose 6-phosphatase. This leads to deficiency of glucose as well. That is why these children develop hypoglycemia. Okay? And because of accumulation of the metabolites like glucose 6-phosphate in the liver, it also results in hepatomegaly. Okay, these are common features which you can get with any liver glycogen storage disorder. So now you have to know some distinguishing features of von Guericke disease. What are they? It starts from the appearance of the child. Look at this particular child. You can notice the characteristic round facies. Okay, which is also called as a doll-like facies. Okay. Second is that there is some amount of abdominal distension, which is not very obvious in these children. But once you examine them carefully, you will notice that definitely there is abdominal distension, which is again attributed due to hepatomegaly. So don't forget, round facies or the doll-like facial appearance, very characteristic of von Guericke disease. The next set of findings in von Guericke disease is related to some biochemical observations. Let us see what are them. I told that there is deficiency of glucose 6-phosphate. There is increased levels of glucose 6. Okay, I'll do that again. There is deficiency of glucose 6-phosphatase and increased levels of glucose 6-phosphate. And this glucose 6-phosphate enters into the alternate metabolic pathways. Okay, yes. So what are the problems which are going to arise out of this? It can enter into PPP, that is pentose phosphate pathway, which is involved in the purine synthesis. Once the purine breaks down, it will liberate uric acid. Thereby, these children develop increased levels of uric acid or hyperuricemia. The next alternate way of metabolism for glucose 6-phosphate is that it gets converted into pyruvate. And that pyruvate can further get converted to lactate with the help of this pyruvate dehydrogenase enzyme. So there will be accumulation of lactate inside the body, resulting in lactic acidosis. Lactic acidosis. Next, the pyruvate can get channelized into acetyl-CoA synthesis, resulting in increased levels of acetyl-CoA. Whenever the acetyl-CoA level increases, the fatty acid production also will increase. And because of increased fatty acids, you will have hyperlipidemia. Hyperlipidemia. these three findings, namely hyperuricemia, lactic acidosis, and hyperlipidemia, are characteristic biochemical abnormalities noted in a patient with von Guericke disease. I have told you about some of the characteristic physical examination findings as well as biochemical findings in case of von Guericke disease. Another important associated finding is when you do the ultrasound, the imaging studies, you will always notice that in addition to hepatomegaly, they also have renomegaly, that is enlargement of the kidney. This is an important finding which can actually help in differentiating from other glycogen storage disorders also. I'll come back to that discussion in a while. As of now, let us concentrate mainly on von Guericke disease. Okay, so having studied about the features of von Guericke disease, you should now know how to manage a child with von Guericke disease or treatment. Remember the main feature in von Guericke disease. What is that? Fasting hypoglycemia. So very simple, you should not allow these children to go into fasting. That is why it is recommended that you give frequent feeding for these children. Every 3 to 4 hours, these children should be fed something so that they don't enter into fasting. If they don't enter into fasting, they don't develop hypoglycemia. Very simple. Okay. Next important point is that night time. You can wake the child and can give frequent feeds. But for a small child like infancy, it is not possible all the time. So for small children, it is recommended that during the night time, you can give nasogastric drip feeds. So you put the nasogastric tube and at frequent intervals like every 3 to 4 hours, you keep on giving some amount of glucose through that feeding tube. That is what is recommended. For very small children, you can also advise giving milk through the nasogastric tube. That will take care of the glucose requirements and avoid fasting during that night time. Okay, right. So that is one thing which is frequent feeding. Next thing is in every meal, you can add some amount of uncooked corn starch. What is the advantage of this uncooked starch? It releases small amounts of glucose at frequent intervals. So it is something like it would prevent the state of fasting by slowly and steadily releasing glucose at frequent intervals. That is why you are adding uncooked starch in the management of children with glycogen storage disorders. Another feeding option in older children is that for overnight slow release of glucose, you can also advise something called as waxy maize modified starch. Overcoming the overnight episodes of hypoglycemia. Okay, so remember, frequent feeding is a basic thing which you have to remember. This uncooked starch administration as well as heat modified waxy maize starch administration are all additional things to prevent episodes of fasting hypoglycemia. Okay, that is all about the management of the most common type of glycogen storage disorder, which is von Guericke disease. Now I am going to tell you quickly some salient points about the other types of glycogen storage disorders. I will strictly discuss these points with relation to MCQ exams. One is about type 3 glycogen storage disorder, right, which is called as a Cory's disease. And if you remember that it is occurring due to deficiency of debranching enzyme. A typical feature of Cory's disease is that it also is associated with fasting hypoglycemia with hepatomegaly like von Guericke disease only, because it's a liver glycogen storage disorder. However, some cases can have muscle involvement. Very, very important point. So these patients also can have episodes of exertional fatigue like a muscle GST. That's the first point of difference. The second point of difference is that they don't have any biochemical abnormalities noted with von Guericke disease. Like, they won't have any hyperuricemia, they won't have lactic acidosis, and they won't have hyperlipidemia. Whereas all the three associations are noted with von Guericke disease, which I explained before. That is the second point of difference. Third point of difference is, I told in von Guericke disease, if you do ultrasound, you can detect rhinomegaly. But Cory's disease, there is no rhinomegaly. Okay. Instead, some of these patients can have splenomegaly. Splenomegaly present. So these are the important points of difference between Cory's disease from the von Guericke disease. Next, about type 4 glycogen storage disorder. What is type 4? It is Anderson's disease. Please remember, this Anderson's disease is characterized by deficiency of debranching enzyme. And here is an important point. The abnormal type of glycogen which accumulates in Anderson disease can cause liver damage. And because of the liver damage, it can lead on to early onset cirrhosis. Very important point. Okay. So when cirrhosis develops, you all know that the prognosis is not going to be good. So if there is a question asked like which type of glycogen storage disease has the worst outcome or the worst prognosis, answer is straight away going to be Anderson's disease. It has got the worst prognosis because it is associated with cirrhosis of the liver and increased risk of death. The next glycogen storage disease is a type of muscle glycogen storage disease, which is type 2 or the Pompe's disease. Now in Pompe's disease, if you remember, I have told previously that it is acid maltase deficiency. Please note that acid maltase is also a lysosomal enzyme. So Pompe's disease will also be one of the types of lysosomal storage disorders as well. So it comes under two categories of metabolic disorders. One is glycogen storage disease, other one is lysosomal storage disorder. Okay, right. Second point about Pompe's disease is that it is a muscle glycogen storage disorder where skeletal muscles are affected. But in addition to skeletal muscles, cardiac muscles are also affected. That is an important point to be noted. Okay, because generally when we talk about muscle glycogen storage disorder, we are talking about only skeletal muscle. But here, in addition to skeletal muscle, cardiac muscles are also affected. The typical manifestation is hypertrophic cardiomyopathy. And this hypertrophic cardiomyopathy can also lead on to cardiac failure. Okay, right. So that is one set of manifestations. The next set of manifestation in Pompe's disease is that they have involvement of liver also. So they will have features of liver glycogen storage disorder like hypoglycemia also. That should be remembered. Okay. Third important point is they have macroglossia as a manifestation. And also one very characteristic feature is severe hypotonia. So the baby will have very less strength of the muscle, or in other words, it appears as a floppy baby or a floppy infant. These are all some of the characteristic associations of Pompe's disease that are commonly asked in the exams, right? So because of lot of main organs affected, like the heart and the liver affected, prognosis is usually not good in this particular condition. However, from a therapeutic aspect, this condition is slightly better because the acid maltase enzyme is amenable for replacement. Or in other words, for Pompe's disease as a therapeutic option, we have ERT, which is enzyme replacement therapy. So this is a very commonly asked exam question. Out of all glycogen storage disorder, only one disease which is amenable for enzyme replacement therapy is type 2 or the Pompe's disease. Okay, so that is about some of the important points regarding glycogen storage disorders from the exam point of view. Next, we are moving on to other metabolic disorders. that is about the tyrosinemia. Okay, so obviously it is a condition due to defect in the tyrosine metabolic pathways. There are three types of tyrosinemias: type 1, type 2 and type 3. But the most common type overall is type 1, and that is what I will be discussing in detail first. Type 1 tyrosinemia is an autosomal recessive disorder due to deficiency of an enzyme called FAH. What is that? Fumarate hydrolase. Okay, this enzyme deficiency causes tyrosinemia type 1. Let us see in which part of the metabolic pathway of tyrosine this enzyme comes. This is the metabolic pathway associated with tyrosinemia, where you can see the tyrosine breaks down into 4-hydroxyphenylpyruvate, and further into so many steps it is getting converted to fumarate acetoacetate. Finally, fumarate acetoacetate is broken into fumarate and acetoacetate, that is by the help of the enzyme FAH, or the fumarate acetoacetate hydrolase. Now that enzyme is the one which is going to be deficient in case of type 1 tyrosinemia. So you can notice that there will be increased levels of the previous metabolite, which is fumarate acetoacetate. When its level increases, it will get channelized into other metabolic pathways, resulting in the generation of succinyl acetoacetate, which will further convert it into succinyl acetone. So ultimately, the levels of succinyl acetone also will increase in the blood. So in tyrosinemia type 1, you have increased levels of fumarate acetoacetate as well as increased levels of succinyl acetone. This is going to be the problem maker in case of tyrosinemia type 1. They are going to damage the liver in the form of chronic liver disease associated with cirrhosis. Not only that, in the long run, this damaged liver can also be associated with increased risk of hepatocellular carcinoma. Okay, associated with increased risk of hepatocellular carcinoma. And an important point to note here is a tumor marker which is elevated in this condition is alpha fetoprotein. So that is why in these patients we keep following up the levels of AFP, and if the level increases in a rapid way, we have to search for the possibility of hepatocellular carcinoma. Okay, right. So that is one type of damage in tyrosinemia. The second area where damage occurs is in the kidney, especially the tubules of the kidney get affected and they develop a Fanconi-like syndrome, where there is a dysfunction of the proximal tubules of the kidney, so thereby resulting in Fanconi-like syndrome. Because of involvement of liver and kidney in tyrosinemia type 1, this type 1 tyrosinemia is also called as hepatorenal tyrosinemia. Okay. Okay. The next important feature of this type 1 tyrosinemia is that these patients can present with recurrent acute episodes of neuropathies. Especially they present with neuropathy involving the limbs, where they have extreme pain in the limbs associated with vomiting. So acute neuropathic episodes are also common in tyrosinemia type 1. Another important feature of tyrosinemia type 1 is the urine odor. The urine will show the characteristic boiled cabbage odor. Okay, and this is attributed due to generation of methionine metabolites in this condition. Okay, so don't forget the characteristic boiled cabbage odor. So what are the important features? Liver damage in the form of chronic liver disease, kidney damage in the form of Fanconi-like syndrome presentation. Next is recurrent episodes of acute neuropathy, and fourth is boiled cabbage odor. These are the 4 characteristic features of tyrosinemia type 1. How do you make a diagnosis? You make a diagnosis by measuring the levels of succinyl acetone in the urine. Obviously what will happen? There will be increased levels of succinyl acetone in the urine, and that is how you will make a diagnosis of this particular condition. This is also a commonly asked exam question. Now finally, coming to the management of tyrosinemia. Remember that you have to reduce the intake of phenylalanine as well as tyrosine in the diet. Why? Because we know that phenylalanine is ultimately going to be converted to tyrosine. So if you decrease the generation of phenylalanine, tyrosine generation also will be decreased. If the tyrosine generation is decreased, there will be decreased production of this metabolites like fumarate acetoacetate. Okay, right. Next important is usage of a drug called as nitisinone. See, before I discuss about nitisinone, remember that this step, that is conversion of 4-hydroxyphenyl pyruvate into homogeneous state, is by an enzyme called 4-HPPD. I'll write above. HPPD or 4-HPPD refers to 4-hydroxyphenyl pyruvate dioxygenase. Okay. So there is a drug called as nitisinone. What does nitisinone do? It is going to inhibit this 4-HPPD enzyme. So when it is going to inhibit, this step will not occur. When this step is not going to occur, the remaining steps all will not occur. So definitely there will be decreased levels of fumarate acetoacetate. If there are decreased levels, there will be decreased levels of succinyl acetone as well, thereby decreasing further damage to the liver and the kidneys. Okay. So this drug nitisinone is considered as the drug of choice in tyrosinemia type 1. Okay. So that is all about the discussion of the common type of tyrosinemia, which is tyrosinemia type 1. Now, some salient features about other types of tyrosinemia. Tyrosinemia type 2 is characterized by deficiency of an enzyme called TAT. What is that? Tyrosine amino transferase. That is what is TAT. Where is this TAT in the tyrosinemia pathway? It is involved in the conversion of this step, that is conversion of tyrosine into 4-hydroxyphenyl pyruvate. Okay, so that enzyme is deficient, thereby resulting in accumulation of tyrosine, and that is what is tyrosinemia type 2. The classical features of this condition include corneal ulcers as well as this characteristic finding which you see here. Can you notice in that skin there is some rough patches which are noted, and there are also thick patches. This is what we call it as keratosis or keratoderma. Simply excess of keratin resulting in thick or giving a rough texture to the skin. Okay, and in case of tyrosinemia type 2, they are usually present in the palms and the soles. So this is called as palmoplantar keratoderma. Okay, palmoplantar keratoderma. Okay, right. And these are usually painful lesions and non-pruritic lesions. Because of eye involvement as well as skin involvement, this tyrosinemia type 2 is also called as oculocutaneous type of tyrosinemia. Okay. In addition to the above manifestation, they can also have episodes of neurological dysfunction. That is about tyrosinemia type 2. Next is about the tyrosinemia type 3. This is the least common type of tyrosinemia and not many cases are reported in literature. So it is more than enough if you just remember only the very must know salient points. What is that? It is characterized by deficiency of 4-HPPD. I have already told the name of this enzyme. What is that? 4-hydroxy-phenylpyruvate dioxygenase enzyme deficiency. And this condition is supposed to be a very severe form of tyrosinemia because it is characterized by a lot of neurological manifestation, which includes developmental delay, ataxia, as well as seizures. Okay, these are the characteristic features of type 3 tyrosinemia. An important distinguishing point to note here is both tyrosinemia type 2 and type 3 liver and renal functions are absolutely normal. Both liver and renal functions are damaged. That is why type 1 was actually called as hepatorenal tyrosinemia. So those are some of the salient points regarding different types of tyrosinemia that one should know about. Next is a condition of galactosemia, which is again one more autosomal recessively inherited disorder. Just like many of the metabolic liver disorders, this is also autosomal recessive in inheritance. Before going into the features of galactosemia, let's have a basic look at what are the problems with relation to enzyme defect in galactosemia. This is the basic review of galactose metabolism, which you've already read in your biochemistry sessions. Just a quick go through with relation to galactosemia. You can see that the first one is a galactose, which is converted to galactose 1-phosphate. That galactose 1-phosphate is going to be converted to glucose 1-phosphate, and that glucose comes from UDP glucose. Okay. Now you can notice that some important enzymes are there in this pathway. One is the enzyme which converts galactose into galactose 1-phosphate, that is galactokinase. Second is the enzyme which helps in the conversion of galactose 1-phosphate to glucose 1-phosphate, and that is galactose 1-phosphate uridyl transferase, which is remembered in the short form as GALT. And there is a third enzyme which interconverts UDP galactose and UDP glucose. What is that? It is epimerase enzyme. So these are three main enzymes, namely galactokinase, galactose 1-phosphate uridyl transferase, and epimerase, which are involved in the pathway of galactose metabolism. Any of this enzyme can be deficient, resulting in the accumulation of galactose or its metabolites, and that is what we call it as galactosemia. Okay. Now coming to the question, which is the most common type of enzyme deficiency? It is GALT. This is the most common type of enzyme deficiency in galactosemia. So what will accumulate? Galactose 1-phosphate will accumulate in the body. This is the basic pathophysiology in galactosemia. I'm going to write that there is accumulation of galactose 1-phosphate. This is because of deficiency of the enzyme GALT. GALT stands for galactose 1-phosphate uridyl transferase. What are the features of galactosemia? Remember, the clinical manifestations of galactosemia will start in the neonatal period soon after the initiation of breastfeeds. Why? Because breastfeeds is giving breast milk to the baby. Milk always contains lactose. From lactose only you are going to get galactose. Okay, so the source of galactose is the lactose content in the milk. So that is why as soon as the milk is initiated in the baby in the form of breast milk, the symptoms will start to develop. What is the problem? Galactose has to be ultimately converted to glucose. That is what we saw in the previous metabolic pathway. That does not happen in case of galactosemia. Thereby, deficiency of glucose occurs and the child will develop hypoglycemia. Sometimes the hypoglycemia can present with seizures also. So this is one of the conditions associated with hypoglycemic seizures in the newborn period. The second important feature is the liver damage. In the initial stages, most of these patients will have hepatomegaly. However, in the late stages, they can develop acute or chronic liver disease, CLD, and ultimately it can even lead on to cirrhosis. So liver damage is an important feature. Third important feature is that it can also cause damage to the kidney in the form of Fanconi-like syndrome. Recollect, in Fanconi-like syndrome, which part of the kidney is affected? Yes, it is the renal tubules, especially the proximal tubules are getting affected. Third important manifestation is occurring in the eye. What is that? We know that galactose 1-phosphate is going to accumulate. That will get converted to galactitol. That galactitol can help in the generation of dulcitol. This gets deposited in the lens, resulting in the formation of cataract. The characteristic cataract associated with galactosemia is oil drop cataract. Okay, very commonly asked exam question, so you should make a note of it. So please remember, these manifestations are going to start soon after the breastfeeds are introduced. Okay, that is why whenever you get a clinical scenario question in galactosemia, the question will always start like this, something like a 1 month or a newborn baby or a baby who's just few months old, and the question will specifically mention exclusively breastfed baby, okay, just to correlate the association of exclusive breastfeeding with the development of problems in galactosemia. That is a point to be noted. Second important one-liner question, what is the cause of death in children with galactosemia? It is due to infection by E. coli or E. coli sepsis. So untreated galactosemia, the cause of death is E. coli sepsis. This is again one more importantly asked MCQ question. Okay, right. Now, there are also some late complications associated with galactosemia. These include speech defect. Mainly, there is a delay in attaining the speech milestones. They also have apraxia and females have an increased incidence of ovarian failure. By the time they reach adolescence, ovarian failure occurs. So the ovary fails to produce sufficient amount of estrogen that can result in delayed puberty in these children. Okay. So those are the late complications in case of galactosemia. So what are the investigations to arrive at a diagnosis? You can do the Benedict's test. That Benedict test is going to detect the reducing substances in the urine. Galactose is one of the reducing substances, so this Benedict's test is going to be positive. However, this is not a confirmatory test because any reducing sugar can give rise to Benedict's positivity. So the confirmatory test is going to be assay of GALT, okay, in the RBCs. So you look for the levels of the enzymes in the RBC, and that will be the diagnostic test. But please remember, most of the times we may not do this diagnostic test, and clinically itself you will make the diagnosis based on association that after the breastfeeds is introduced, all the problems are developing, especially hypoglycemia, liver damage, renal damage, and also cataract as a manifestation. Okay, right. So having detected cases of galactosemia, how are you going to treat them? Very, very important is you have to eliminate galactose from the diet. Okay, lifelong galactose has to be eliminated from the diet. We know that the important source of galactose is the milk, including the breastfeeds. Okay, so in these children, you have to completely avoid breast milk. Or in other words, breastfeeding is an absolute contraindication, a very, very important question. So what type of milk you can use? You should not use any type of milk, whether it's a breast milk or a cow milk, because everything contains lactose. You have to give formula feeds without any lactose, or no lactose formula is advisable. Okay, number one. You can also use soy-based formulas, which can also be used in the management of these children. Okay, right. Our basic idea is to avoid any source of galactose in the diet. Because they are not taking milk, they can develop deficiency of calcium and also vitamin D. So you have to supplement them with calcium as well as vitamin D. Absolutely essential for these children. Okay, in these children, to test for the assessment of compliance, you can estimate the levels of galactose 1-phosphate in RBCs. Okay. If the galactose 1-phosphate levels are normal in the RBC, it means the patient is compliant to treatment. If the galactose 1-phosphate level is elevated in the RBC, it means the patient is non-compliant to treatment. Okay, that is how we say that there is compliance in cases who are treated for galactosemia. That is about the discussion of galactosemia. Last in this group of metabolic liver disorders is a condition of HFI or hereditary fructose intolerance. So this is a metabolic disorder related to the fructose pathway, and it is again an autosomal recessive disorder, and the defect in this condition is deficiency of an enzyme called aldolase B. The complete name of this enzyme is fructose, FRU for fructose, 1-phosphate aldolase B. That is the complete name of this particular enzyme. So what is going to happen? Here again there is accumulation of fructose inside the body. That fructose is not going to be converted to glucose, thereby again resulting in the development of hypoglycemia. However, an important point to be noted is when the symptoms will start. Remember, when are you going to introduce fructose in the diet? Fructose, we all know that it is present in the fruits, juices like that, which will be introduced only after 6 months. So after 6 months only, the symptoms are also going to start in case of hereditary fructose intolerance. A very important point and a distinguishing point from the previous condition of galactosemia. In galactosemia, symptoms will start soon after birth when the breast milk is introduced, but in hereditary fructose intolerance, it will start only after 6 months. Basically because fructose is introduced in the diet only after 6 months in the form of fruits. Okay, right. I can recollect a case of hereditary fructose intolerance when I was doing my postgraduate residency. At the time, we had a child in the ward admitted for evaluation of unknown liver disease. Because that child had jaundice and hepatomegaly, the child was admitted. One very peculiar finding we noted in that child was the mother also complained the same thing. What is that? Whenever we give chocolate to that child refused to take that chocolate at all. The mother was saying like this very characteristically, my child is completely avoiding chocolates. Not only chocolates, even sweets or any form of fruits also. And that is the time when we thought about the diagnosis of hereditary fructose intolerance. Why? Because this sugars, fruits, everything can contain this sucrose or fructose, to which the child is developing a problem because the child has hereditary fructose intolerance. So what happened? They will deliberately avoid all forms of sugar, sweet or the fruits. This is a characteristic feature which is called as self-restriction or aversion to sweet intake. Very characteristic. If that line is given in the question, the diagnosis is only hereditary fructose intolerance, nothing else. Okay, right. So the features of this condition is starting after 6 months in the form of hypoglycemia. They can also have liver dysfunction as well as renal dysfunction, similar to what we studied in galactosemia. But an important difference is there is no cataract formation. Why this is important to know? Because for cataract formation, remember in the previous discussion I said you need to have galactitol or dulcitol, which is never going to be associated with fructose pathways. So there is no dulcitol or galactitol here. So there is no cataract formation in this condition. Very simple. Okay, right. So how are you going to investigate these children? You can do the urine analysis, which will reveal the presence of fructose or there is fructose urea. Okay. However, the confirmatory test for diagnosis is you have to do enzyme assay in the liver tissue. That is the usual confirmatory test. What enzyme? It is aldolase B enzyme assay. That is what we are going to do as a confirmatory test. Okay. Again, what is the treatment? You have to avoid sucrose, fructose, as well as sorbitol in the diet, because all of them contain some form of fructose, which is going to cause problems in these children. So all these should be avoided. Second important and a very practical point is, if you have noticed that many of the medications, I'm talking about the suspensions on the syrup, okay, which we give as treatment options, okay, whenever the child gets fever, cough, antibiotic, everything, if you see, there is a suspension, okay. And if you have seen the suspension, it comes in very, very delicious flavors. Have you noticed that? Mango flavor, strawberry flavor and all, okay. What they contain the fruit extract, or they contain the sucrose. Do you want to give to these children? Absolutely no, because any form of fruit exposure or sucrose exposure is going to cause problems in children with hereditary fructose intolerance. So remember this, any form of drugs or vitamin supplements in a sucrose base, or simply remember any form of flavored syrup, I am talking about the fruit flavored syrups, should always be avoided in a child with hereditary fructose intolerance. So that is about the discussion of hereditary fructose intolerance, and I am ending the module on metabolic liver diseases in children.